All right, welcome everybody to a new year of the Medicaid Client Voice Council. My name is Jason Peterson, Deputy Chief of Community Engagement. We're going to get started because we've got a pretty full agenda. We've got a couple housekeeping items. Since we are in a new space here, I wanted to let you know that if you need to use the restroom, if you need coffee, if you need water, it's all right through that doorway over there. Some members have let me know they're not going to be able to make it today, either due to illness. One had her car towed last night, which really stinks because when that happens, you need to take care of that immediately or the price keeps going up and up and up. So she regrets that she couldn't make it. A couple will be coming in late, so some of familiar faces will still be coming in. But how many of you have kept your New Year's resolution so far? Any successes or failures already? Or are you like me, just if you don't make it, you can't fail, right? You probably heard when you came in the COVID levels have dropped since we announced this meeting, so masks are once again optional, but feel free to wear one if you are more comfortable with that, but it's no longer required. We're going to take photos of the new members right when we break for lunch. So when we break for lunch at noon, the new members are going to go across the street up into the building and to the third floor where there's a Capitol View room where we take pictures of the new members. And then you'll still have plenty of time to come back and eat. But while the rest of the members break for lunch, you'll go over and have your photo taken real quick. When you leave, before you leave today, leave your name tags, sign your forms in your packet for reimbursement purposes. Be sure to do that. And there was one other thing they wanted me to remind you to do. Your folder, leave your folder so they don't have to recreate your folder each time. If there are any spelling problems with your name tags or your folders or anything, bring that to my attention and I can let AFMC know and we can get that fixed for next time. And we apologize for this time. So as I mentioned, we've got a lot of changes since last year, a new location, some new members we're going to meet in just a moment, and new leadership at the Department of Human Services. I will be using a microphone as I go around the room. And that's only for our purposes of our online viewers. There are people watching online, and when I go out into the audience, they want to be able to hear what you're saying as well. So this microphone will pick up the speakers. This microphone will pick up all of the people that when I go around with the microphone. But we'd like to invite our new secretary to the podium. She would like to greet you, say hi to you, let her know what her thoughts are on the Medicaid Client Voice Council, and then she in turn will introduce her deputy director and the state director of Medicaid. So if I would, could you please welcome with me our new Secretary of the Department of Human Services, Christy Putnam.
Thank you. Can you hear me in the back? Is that good? Okay, I don't like microphones. I'm Christy Putnam. It is an honor and a privilege to be here. I am new Secretary of the Department of Human Services, and I come to you by way of Kentucky. So I have spent 7.5 years in Kentucky, and most recently I was the Deputy Secretary there for their Cabinet for Health and Family Services. I've spent a lot of time, Kentucky has a similar version of the Medicaid Council, and spent a lot of time working with them, speaking with them, and just really learning from them. I look forward to doing the same with all of you, and just appreciate the opportunity to be here, and I'd love the chance to visit with each one of you as time permits, today, and certainly reach out throughout the next few weeks and months. It's been a busy week last week, but I am very excited to be here. Just a tiny bit of background. I have come about 20 plus years of state government. I can't seem to kick the habit. I keep going back into state government. Good policy and really working with people and building collaborative ideas and new practice is what I love to do. I love seeing cabinets work together. So one of the things you'll see hopefully a lot of is Department of Human Services reaching out across to Department of Education, Corrections, to all the other sister cabinets, because I think the best work done is work that we do together. So with that, again, thank you for being here today. I look forward to getting to know each and every one of you, and I would like to introduce Janet Mann, who is Deputy for Health and State Medicaid Director.
Good morning. I don't like a microphone, so we just won't even worry about it because I'm too short for it. I have a very loud voice at times. I'm Janet Mann. I'm very happy to be here. This is my third job with DHS, so I cannot kick the habit of coming back to Arkansas DHS. So I'm very happy to be in this role and working with y'all, and looking forward to doing all kinds of fun and different exciting things as we enter this new year. Grew up and lived in Mississippi for most of my life with different stints doing different, policy work in different states. But I really have grown to love Little Rock as I keep coming back. So a little bit of my background is I'm an accountant by education. I still maintain my CPA as just a nod to my parents primarily, who would probably be very upset if I did not keep my initials behind my name. In addition to that, I call myself a Medicaid nerd because I like all things Medicaid, which is why I like the policy along with the finances. So just a little bit, but I look forward to getting to know you and working with you. And I don't know my phone number yet, but you know, I can easily be found in the secretary's office or with one of the division directors. So look forward to working with you. Thank you.
Thank you, Christy and Janet. We also have a change at the top for the Medicaid Client Voice Council. Chairperson Allison Caballero served as our chairperson for the past year. Jerry Watson, vice chairperson, will be taking over for this year, and one of you new members will have the opportunity to become the vice chairman for this year and the chairperson for next year. So at the end of the meeting, be thinking, new members, if you would like to be that person, and at the end of the meeting, we've set aside 15 minutes for you to make your best case to the council, and then we'll take a vote on who will serve this year as vice chairperson. So we would like to meet first the returning members and then the new members. So Jerry, if you would grab your microphone and first tell us a little bit about yourself so we can meet you again, and then we will meet all of the returning and new members of the council before we get on to today's business.
My name is Jerry Watson, Reverend Jerry Watson. I've been on the council for a year now, and I was elected as the vice chair. And as of today, I'm the chair. The vice chair becomes the chair the next year. And I look forward to working with whoever gets selected as the new vice chair to help you do the best job you can as chairperson once you become chair. So today we're going to give people a chance to introduce themselves. I have a list here. First, we have Deandra Bass Kerrigan.
Deandra was running late. So
Oh, okay. And next we have Erica.
And Erica's not here today.
Oh, wow. Next we have Laura Cartwright.
I'm Laura Cartwright. I'm from the Northwest Arkansas area. Recently moved to Lincoln, which is almost in Oklahoma, but I'm the mother of 7 boys. The youngest 4 are adopted through Child Protective Services in Texas. We moved to Arkansas 12 years ago. My youngest is a resident of the Human Development Center in Jonesboro, and we've navigated Medicaid many years. I'm also a teacher in the school systems and have taught self-contained for classes for 21 years.
All right.
Okay, next we have Nathan Dyke.
Hi, my name is Nathan Dyke. I am from the Area 1 region. That's Fort Smith, Van Buren, actually. Van Buren is a different county. As Reverend Watson said, I've been on the council for a year. I have experience in 8+ Medicaid-funded programs, and I look forward to continue serving this council.
Amen. Next we have Deborah Eckel. Okay, next we have Lysandra Glover. Cassandra Glover.
So again, I'm Cassandra Glover. I'm a resident of Searcy, Arkansas. I have a 3-year-old son named Derek, and Medicaid was really beneficial for myself and my son, especially when I was going to grad school for social work. Currently, I'm also working at Arkansas Advocates for Children and Families, and I serve as their health policy analyst, and I look forward to working with everyone else who's joined the council.
Next is Frank Helmer.
Hello, everybody. My name is Frank Helmer, and I'm a client with autism on the DDS waiver, and I graduated from Arkansas Tech with a degree in accounting and business data analytics before passing the CPA exam. I don't have the CPA license, but I work as a data analyst for Centene, and my goal in life is to glorify my Lord and Savior Jesus Christ as much as I can by doing the most impact for others with my talents that He has given me.
Amen. Next, we have Michelle Lappin. Bradley Ledgerwood.
I'm Bradley Ledgerwood. I'm from Cache, Arkansas. Currently serve on the Cache City Council, and I have a passion for politics. I enjoy advocating for people that can't advocate for themselves.
Next, we have Ketty Kaniski. Next, Amanda Sanders.
I'm Amanda Sanders. I live in Mountain Home, Arkansas. I have 3 sons. My oldest son has autism. We've been actually applying for the waiver for 22 years. And we found out that we are now about to get it. And so, I serve on this council as well as the Governor's Disability Council. And just have spent a lot of time volunteering and working to get the waiver. And so we're about to enter into a big change, and are excited about that, and excited to see what we're going to be doing here. Thank you.
Next, we have Reba Shipley.
My name is Reba Shipley, and I live in Jonesboro, Arkansas. I am the mother to 12 children. I have 5 children with disabilities. I have a spastic quad child. I have a child that's legally blind, has schizencephaly. I have a child that has heart conditions and lung conditions. I have a child that has autism, and I have a child that has seizures. And these children came into our home by choice. We chose to adopt them. We fell in love with them, and we are so thankful for Medicaid. It has really helped our family, and it has given these children the opportunity to flourish in an environment to where maybe if they were somewhere else, they would not have been able to flourish. I serve in the accounting field, and I just enjoy working with kiddos in my community, and look forward to working with you guys as well.
Okay. And next, we have Deronda Williams. Okay. Now we get to our new members.
Let's go to Allison, too.
Oh, I'm sorry, Allison.
Hey everybody, I'm Allison Caballero. I was honored to serve as this group's inaugural chair last year, and just super excited that I get to stick around for 1 more year. So on that note, if you're thinking about throwing your name in the hat for vice chair and you want to know what that's all about, and if Jerry is busy with another prospective applicant, come find me and I'll be happy to tell you about it. I think it's a great experience for you to serve. That's why we're all here. And if you're worried that you haven't done any public speaking or led groups before, what an opportunity to learn and grow. And Jerry will be right beside you the whole way. So don't let that stop you just because you haven't done it before. So I've got a kiddo who has some special needs. She just turned 15. She attends school at Access here in town. We're from Little Rock. She has been on TEFRA since as long as I can remember. Thank goodness for that. And she too is coming off of the waiver waiting list. Woohoo! And I want to acknowledge our friends in the room from DHS who have helped me navigate some of those processes. This is also a lovely opportunity to get to know folks who can help you if you can't get what you need through traditional means. So thank you all for that, and looking forward to another year.
Thank you, Allison. Next, we have a new members, Brittany Gilmore. Gail Holloway.
I'm Gail Holloway, and I come from the long, sharp county, which is up by the Missouri line in Hardy. I'm born and raised in Jonesboro. I'm off the waiver list. We had twin girls that we waited 18 years for, but we got services. They're wonderful. You will appreciate them every day. They're worth waiting for. My husband and I was an educator, 28 years, taught in public school, then was the director of a psychiatric center, and then I taught at Arkansas State University. and worked on the Delta Grant Program, one of the largest grants that was ever awarded to Arkansas State University, and I got to be a part of that. We also, my husband and I, 33 years, we left Jonesboro and moved to a 300-acre cattle farm. Yeah, and so we're raising cattle. And we also now have our 4 children. We did foster care in Craighead County. Through the foster care system, we adopted twin girls and our son, and then we gave birth to a son along the way. And now then some are still with us. They have an array of abilities and disabilities. And then we also now are blessed with a granddaughter who we have legal custody of, and she's 5, and she is autistic. We have a home in Mountain Home, and so when we're not working with cattle or something, then we get to go up to Mountain Home and visit and play on the lake for a while. So it's nice to be here.
Thank you.
Thank you. Next, we have Heather Honecker.
Hello, I'm Heather Honecker. I live in Little Rock. I have 3 children. My middle child, Ellie, is 4 years old, and she was born with Down syndrome and also other complex medical conditions. So we have been a part of the program, the TEFRA program, since she was born. I'm really excited to be here and learn more about our programs and get to work with all of you.
Okay, next we have Kevin Hoover. How you doing?
Hi, y'all. My name is Kevin Hoover. I'm originally from, here in Arkansas. Born in Eureka Springs, so I know the northern part of the state really well. Live in Greenbrier. I have 2 wonderful young daughters. I say young now. And blessed with 8 grandkids and waiting on the great. He's awfully slow. This is my first time on anything like this, but I am looking forward to seeing how it goes around. Thank y'all.
Next, we have Michelle Pedro. I'm sorry, Atandra McClure.
Good morning. My name is Etandra McClure. I'm born and raised from West Memphis, Arkansas, relocated to Little Rock, Arkansas in 2018 with my daughter, Jalea. She's 16 and she receives TEFRA benefits. And TEFRA's been really great for us. I believe I tell anybody the benefits saved her life. If it hadn't been for benefits helping me and my household, I don't know. But I'm excited to be here and work with all of you and get to know more about other programs that the state of Arkansas offers for us. Thank you.
Kristen Arnold.
Good morning. My name's Kristen Arnold, and my family adopted a 3-month-old little boy. He's 24 now. I'm his legal guardian and his sister. Medicaid has been wonderful. He's on waiver. Since he was a foster kiddo, he was able to get priority. I'm such an advocate. I love this program. It has helped so many people. I'm a supervisor with the Pass Empower, and so I live both sides, and I'm just, I'm so proud. I'm so excited to be here, and as you see, I'm gonna cry. I'm very passionate, so I'm very excited to see everything that we do. And I live in Conway.
And next we have Michelle Pedro.
She's not here today.
Okay. Next we have Betty Rayford.
Okay. Hi, I'm Betty Rayford. I'm from Pine Bluff, well, actually, south of Pine Bluff. I have a 35-year-old son who has Down syndrome. He's been in the Medicaid program since he was 7. He was on waiver since he was 7, so I've traversed all those possibilities and impossibilities and can offer a little bit of advice on that. I've been in advocacy services for a long time, was originally on the Governor's Council for Developmental Disabilities for a long time, And a group of parents actually developed our own Parents for Inclusive Communities quite a while ago to advocate for children around the state. Also have done quite a bit of advocacy for children in the education system when they needed services and didn't even have anybody to hold their hand. If you can imagine 35 years ago, it looked a lot different than it does now. But I have to say, he's graduated high school. He's now part-time employed at Walmart and is doing excellent. So services do help.
Amen. And Yolanda Traylor.
Good morning, everyone. My name is Yolanda Traylor, and I am a mother of 2 Jays. I have an older daughter, Jayla, who's 23, and my son, Jathan. He is 14. He'll be 15 in March, and he has special needs, and so he just started high school at Maumelle High School. And so that's what I do during the day, and we work through the PASS with Arkansas Total Care, and we are so proud to be associated with them. And Monday through Friday, I am started as I've been in early childhood education for 22 years, and so right now I'm a director at a preschool in Maumelle, and so I am very excited to be here to not only learn about my child, but other ways that I can advocate for the kids that we serve in our center.
Okay, I didn't really give an introduction of myself, so I'm going to go ahead and do that. My name is Reverend Jerry Watson. I'm a caregiver for my 2 disabled sisters who are on Medicaid. Also, I'm the founder of Delta STEM Stars, STEM, Science, Technology, Engineering, and Mathematics. My goal is to use technology to help end poverty in Arkansas, and I'm glad to be here. If you have any questions about technology or anything, let me know.
And DeAndrea came in while we were doing it.
Okay, DeAndrea?
Get a chance to get yourself, where you're from, why you're on.
Hi, everyone. I am Dr. DeAndrea Bass Kerrigan. I am from Conway, Arkansas. My role, my employment, I am with Central Baptist College. I'm the department chair of the psychology department. Which I think my role is twofold. I'm also a mom to a senior, boo-hooing, keeping myself together, who's going to be graduating. He is my super senior. He has cerebral palsy, and we're looking forward to graduating. Everyone keeps saying, he can go until he's 21. I don't want to. So we are looking forward to graduating, and I am here just so I can be an advocate for all individuals with disabilities, not just my son.
All right, well, we thought a good place to start, since we've been hearing so much about it at all of our meetings, is the unwinding or the decoupling of benefits to the public health emergency. And so while Amy Webb was going to be here to present that, she had something come up, but you guys are going to do it together? So Mary Franklin and our new Deputy Director, Janet Mann, are going to do that. Also, it came to my attention, I neglected to introduce another one of our new Deputy Directors. Misha Martin is here with us today as well. So we have the 3 power brokers at DHS all here at this meeting, so we appreciate that, Misha. Thanks for being here. So without further ado, we're going to learn a little bit more, give you guys a real brief update on where we stand as far as the unwinding of the public health emergency.
Could not be here, but Mary has all the details and is the expert, so I'm going to let you kind of take the lead.
Well, good morning, everyone. For those of you who I haven't met previously, I'm Mary Franklin. I'm the director of the Division of County Operations. In County Operations, we determine eligibility for Medicaid. We have offices all over the state. We also handle the SNAP program, Supplemental Nutrition Assistance Program, the Transitional Assistance Program, and we also administer some grant programs which we administer through other agencies, the Community Service Block Grant through the Community Action Agencies, and a grant called Emergency Solutions Grants, which focuses on ending and reducing homelessness, that we also subgrant to community organizations throughout the state. And we also help refugees through the Refugee Resettlement Program, Resettle in Arkansas. But last meeting, I know many of you were not here, but one of our topics in the last meeting in December, I think it was in December, was an overview of our PHE public health emergency. Forgive me for the acronyms, we just use them all the time. public health emergency unwind plans, how we've been getting ready to do the unwind, and all the things that we have in place and what we have been doing to help prepare for the public health emergency unwind. Well, since December, there has been a change. In December, we did not know when it was going to end, but legislation was passed, federal legislation was passed that, well, let me back up just a little bit since everybody wasn't here in December. Since March of 2020, we have done continuous enrollment for Medicaid clients. We have not closed them except for specific reasons, such as death, moved from the state, they asked us to close their case, or they became incarcerated. We have continued Medicaid coverage since March of 2020 when the PHE began as a result of a law, a federal law that was passed that offered states additional funding, additional percentage in the match that we get to cover Medicaid. And so Arkansas, since that time, has been extending Medicaid coverage. And in December, when we met and went over our unwind plan, this new law had not been passed at that point. So the new law that passed, what it did was separate the requirement to continue Medicaid eligibility from the end of the PHE. So now we know when the Medicaid unwinding is going to start. It's going to start April the 1st, based on that new law that was passed. The PHE has not yet ended, and that will be announced at some point later, but we do know and have official instructions now to go ahead and start the Medicaid unwind effective April 1st. So that means people will have continuous coverage like they have through March 31st, but beginning April 1st, reasons that we would normally close a Medicaid case for, we will start doing that effective April 1st. And for our PHE extended group, and we are around, in December, in late December, it was around 398,000. It's a little over 400,000 now that are extended. Like we would have closed them, but we didn't because of this requirement to continue their coverage. But our renewals for that extended population, we're going to do a renewal on everyone before we just close their case if they're extended. Our renewals for that first group that will be impacted in April, they will go out the first weekend of February. And just to let you know which group is going first, that's going to be our home, our kids, parent caretaker that are currently extended due to the public health emergency. And just so you know, we're splitting, it's such a big group, we're splitting them up over 4 months. So we will start with the ones who've been extended the longest, work our way to the ones that have been extended for the least amount of time. And in our home group, we have right now 131,000 clients in our home that are considered extended due to the public health emergency. And that could mean they didn't return paperwork. That could mean we determined they were ineligible for whatever reason, or they could have aged out of the program, but we've kept them extended. There are 110,000 extended kids in our kids A and B, and 76,000 or so adults in the parent caretaker category. And again, we'll split them up over 4 months. For those that are determined ineligible at renewal, just a reminder that they can have an option to access coverage, often at no or low cost through the federal marketplace. So if they're ineligible in Arkansas for the Medicaid program, they may be eligible on the exchange to shop for insurance through the federal marketplace with subsidies.
Yeah, and if I could chime in on the new federal law that passed in December, if members are deemed ineligible and they go to the marketplace, there will be some interaction between DCO and the marketplace, and that is a new requirement for us with the Medicaid program. Usually they get electronic transfer and it's handed off to the marketplace, but there'll be a little more effort to handhold and help them find coverage so that if they can get it on the marketplace, they won't lose coverage. It'll just be in a different format.
And we'll add the long-term services and support categories to our renewal process starting in March. So the March will be the first month that any renewal packets for extended clients go out. And then, just as I mentioned before, No PHE-related cases that are already extended will close before April the 1st, but there will be cases that close March 31st that are not extended. So they would be regular renewals or actions that we would take in March, since March 31st is the end of the continuous enrollment requirement. So there will be closures at the end of March for that group of people. Let's see, what else? I think, and since the PHE has not yet ended, there are some Medicaid flexibilities that have been in place that will continue to be in place until the actual PHE ends. And so those are some flexibilities on the provider side and that nature. So I'll stop there and see if anybody has any questions about this update. Yes, Reverend Watson.
You got a microphone.
Yeah. Will people have an opportunity to appeal
Yes.
the
Yes.
decision that they are ineligible?
Yes, the normal appeal process will exist for all the renewals. They will not be treated differently. So there's an appeal process now for anyone that applies and an adverse action is taken or if a renewal comes up. So that process will go through all the extended population and the regular population.
Okay, I know some people who are on SSI, who receive Medicaid, and they receive SNAP. If they get sick or have to go to the hospital for a couple of weeks and they get a renewal in the mail and they don't respond in a timely manner, they're dropped from their SNAP benefits. And if they don't recognize it within a certain appeal within a certain time, they have to reapply. Will this happen also with Medicaid?
So
because people that are receiving SSI are supposed to be in a category where they automatically qualify.
okay, a couple of things there I wanna provide information about to answer your question. The SNAP program operates differently than Medicaid. In Medicaid, if you're approved in most of the categories, you're given there's no end date. You're approved and we do an annual renewal. If you're eligible, you keep going. SNAP is different in that there are finite periods of time. So if you're approved for SNAP, you're approved for a certain number of months. And that means if you don't provide the paperwork before the end of that last month you're certified, then your coverage does end. But you can certainly reapply and reinstate those benefits. But
I thought the SSI people were in a special category.
so SSI, and also just so that you are aware, you may not realize, in Arkansas, the Social Security Administration determines eligibility for SSI. And at DHS, we approve, we open the case when Social Security tells us to, and we close the case when Social Security tells us to. We do not actually, at DHS, conduct those renewals on SSI cases. Now, if someone who's on SSI also has waiver services, we do redo the renewal on the waiver service, but the SSI program itself, that's done through the Social Security Administration.
For Medicaid, not SNAP.
Correct. We do SNAP at DHS. But yes, the reason why a case might close if someone doesn't return their form, even if they're in the hospital, is because that is just how the SNAP program is designed based on the federal rules. We have a certain number of months and we can't just extend them without going through the recertification renewal process. Any other questions?
She has one. I didn't want to point.
Given that there will be most likely a high volume of appeals, do you have enough staff to cover this?
We are looking at different options of staffing. We are looking internally at adding some, what we call extra help to handle appeals, but they've got to have the expertise and the experience to do that. We're also looking at some contractors. So we do recognize that we don't know what the volume is going to be, that we know that the volume is coming. And so we are trying to get prepared as quickly as possible, not pull that switch too soon, but be able to pull it at the correct time so that the appeals can continue to process regularly.
Yeah, I would be very concerned about that.
I am.
That already it takes a long time.
It does, and
you can foresee that there's going to be an issue. So that's just a big concern.
Thank you. Right behind you, Jason, and right in front of you, sorry.
Just curious, just because I know we're anticipating that in April, and I know that you may not have the numbers right now, but maybe if they could be distributed after, like, is there a current status on the backlog of Medicaid applications, or like, are we currently not backlogged, or is there still pending applications from like 2021, or, I just, if there's some status, just to
No, I think we
give
can get the
context.
detailed information, maybe for the next meeting, and,
But
Well,
I
go
can
ahead.
share, I can share right now, they're around 1,000. We're down to only possibly 1,000 overdue Medicaid applications. We're pretty current processing Medicaid, even Medicaid renewals. We have some overdue renewals and some changes, but it's very low at this point, yeah.
and there was a question, right?
For those that, if you're deemed ineligible and then you file the appeal, what happens to your Medicaid coverage while you're waiting on the appeal?
So, if you are in a long-term service and support category and you file the appeal, we continue the benefits. In other categories, you can request to continue the benefits, so.
Other questions on this topic?
Just a comment and request. The letters that we get about eligibility and various determinations have gotten better over the years, so kudos on that. I think there's still some room to grow there in terms of making
Agreed.
those easy for people to understand and, more importantly, act on, because there's almost always an action required for us. And I find that that's often buried, as are the contact phone numbers. And so there might be a 1-800 helpline, but then there's also this number for your county office. And when it comes to these things, like, okay, you've now been deemed ineligible, but you can maybe go apply to the marketplace. And here's this, I loved what you said about, having kind of a facilitator to help you get onto those services. But like, just to have those options with those action steps and phone numbers very clearly pulled out and labeled as such would be super helpful when those notices come out.
Actually saw a draft notice this morning that had some bold in it, so, but we'll definitely start looking at some other options to be helpful. Yes, sir.
Just a quick follow-up to what Allison was saying. I've noticed, because of my computer background, that when the action notices are sent out, they're dated one day, but when you actually receive them in the mail, it's like 5 days later. Okay, but the counting starts from the day the letter was printed, not the date you received it. And so sometimes, by the time you receive, especially if it's around a holiday, by the time you receive the letter, you only have a couple days before the deadline of responding.
And I definitely understand and am sympathetic to that. We actually date our letters for the next day because we know they're not going out today, they're gonna go out the next day. But the timeframes are based on the date of the letter versus
When received.
and when received, we understand. And I, yeah, Yes, there are some challenges with the mail.
Yes, but I will also make a plug for Access Arkansas, where you can do it all online for
Right.
notifications and updates and even text and emails. So I know, I call it snail mail, can be very slow and time-consuming and frustrating. So I would encourage the other option also.
You were right about the Access Arkansas. That's good, but I know someone, I brought this up at the last meeting, that can't use the Access Arkansas like that because he don't have a credit history.
Oh, okay,
It has to do with the remote identity proofing.
okay, well,
Yeah. Yep.
yeah.
Yeah.
Good intentions sometimes never
Right.
work out well, but we'll work on it.
And the only reason I said that, you need to try to figure out some way of doing it where people that don't have a credit history can get on there, because that was a major problem for them.
Okay.
Yes, I do remember that, and I've taken that back to our team from the last meeting to see if there's a way. If you can't get through remote identity proofing, that we can have an alternative way for you to get an online account. Definitely.
Nathan, did you have
Yes. I have a remark just to add to the remote identity proofing. Why not use something like OTP or email verification or something like that? And the OTP is a one-time passcode through like text message or something like that.
We can look into it.
Yes.
I don't know exactly why that was not chosen as an option, but we can look into why.
That's the most common use of verification today. I understand that it's not as secure, of course, but it's an option.
Yes, sir.
Thank you, Nathan. Thank you for all of those questions, council
Yes.
members. They'll be taken back, and that's what we're here for, to input and improve the policies and procedures that affect not only the people in this room, but everyone in the state on Medicaid. So
Absolutely.
another good place to start this meeting, the first of a new year with some new members, was kind of to do a Medicaid 101. Not a Medicaid 101, a DHS 101. DHS is the biggest state organization, and for you guys to have a good grasp of it is important. And so Mary's going to stay up here, and she has a slideshow, and you also have it in your packets. You can follow along with the slideshow in your packet. We've also included a DHS overview that was given to all the freshman legislators. We changed it a little bit, but it's basically what they received so that they can understand DHS and all the programs and divisions that we have. So,
Are we walking through all of it, or just the Medicaid part? We'll see.
Yeah.
Well, we'll see.
Yeah.
Right away. Okay, the arrow or the green button? The arrow, is that what I used?
I think so.
Let's see what happens.
Yeah. Yep.
Okay, so we'll start with, this is a DHS overview. DHS, we're divided into youth and families, and then health and Medicaid. And Misha Martin, who you met earlier, she is the Deputy Director over Youth and Families, which includes our Division of Children and Family Services, our Division of Child Care and Early Childhood Education, and our Division of Youth Services. On the health and Medicaid side, we have the Division of Aging, Adult, and Behavioral Health Services, Division of County Operations, Division of Developmental Disability Services, Division of Medical Services, and the Division of Provider Services and Quality Assurance. And outside of our divisions, we also have shared services. And shared services is our administrative arm, includes our HR team, our IT team, procurement, legal. It's all of those supportive services that we have to run our agency and do and implement our programs on a daily basis. So our personnel, DHS, and this is as for state fiscal year 23, DHS has 8,242 authorized position. Of that, 7,381 are budgeted, and as of December 9th, we had 6,601 of those positions filled. And in the pie chart, you can see where this is by division and by shared services. So the division with the most employees is Developmental Disability Services, and remember, they manage the HDCs, the Human Development Centers. In county operations, we have 1,781 positions. Children and Family Services is next with 1,301. Child Care has 182. Division of Aging, Adult, and Behavioral Health Services has 1,037. Shared Services 617. DYS 93. DIP Squad 182, and DMS 93. Now, this is a look at the DHS budget. Our annual budget for state fiscal 23 is over $10 billion total. Most of that is federal revenue that we get from the federal government as matching funds or funds to operate our programs. 7.8 of that is federal revenue. 1.8 billion is state general revenue, and then another almost $987 million is from other sources. Just to show how the general revenue is allocated across DHS, the $1.8 billion in general revenue, the majority of it, as you see, the dark blue in the pie chart, goes to Division of Medical Services and essentially goes to provide services to all of our eligible Medicaid clients and programs that serve Medicaid clients. And then you can see the rest of the income, children and family, is one of the largest of the remainder, as well as aging and adult and behavioral health services. All right, Arkansas Medicaid. We want to start talking about the difference in Medicare and Medicaid because it can be confusing, and they're not the same thing. Medicare is a federal insurance program that pays medical bills from a trust fund in which most workers in the country contribute to that trust fund. It serves mostly people 65 and older, regardless of their income, and it does serve some younger people who have disabilities. And essentially the same benefit regardless of what state you live in. Medicare is Medicare. And funding is paid directly to the providers just like health insurance would. Medicaid is what we operate at DHS here in Arkansas. It's an assistance program that serves low-income individuals of all ages. It's jointly funded by the state and the federal government, and with the federal government paying about 76% of the cost here in Arkansas. Medicaid programs can vary from state to state, but they have to operate in any state. The Medicaid program has to operate within federal guidelines, and we must seek approval, federal approval to waive any of those guidelines. And funding is also paid directly to providers just like it would if it was health insurance. Okay, changing the Medicaid program. Every state submits a Medicaid state plan to the Federal Centers for Medicare and Medicaid Services. That is the federal agency that funds Medicaid. It's part of Health and Human Services at the federal level. So if state officials want to change the Medicaid program, we have to submit a state plan amendment or a waiver request. And the difference between a state plan amendment and a waiver request, a state plan amendment is a formal plan to change Medicaid services or operations. It does not have a cost or budget requirement, and about typically a 90-day process with CMS. And once we do a state plan amendment, that change is permanent unless we do another amendment that changes it in the future. Now, a waiver is different from a state plan amendment because that's a request where we're asking CMS to let us waive certain federal requirements. Waivers have to be cost neutral. So if it's approved, it has to not cost more than what we were doing before. And once it's approved, it's official, and they're time limited. Waivers are not indefinite, they're time limited. And just a little bit, providers. These are the providers that accept Medicaid. There are 101,850 providers that can provide services to Medicaid clients and be reimbursed. But in fiscal year 22, there were only 49,240 of those providers that actually billed for a service, meaning they actively provided a service to a Medicaid client. And there are 85 different provider types that Medicaid covers. And Elizabeth Pittman, who's the Director of Medical Services, is going to come and talk to you about Medicaid rates and rate reviews and how that works.
And before I do, I just want to clarify one thing. This is probably more detailed than you want, but I just want to be real clear. The waivers that a lot of you guys are on, the long-term services and support waivers, do not have to be cost neutral. We have to show that they're cost effective, I believe, which is a different thing. It doesn't mean we can't spend more money. It just means we have to show that it's as effective as an institutional level of care. So I just wanted to make that clear because it's a different test and didn't want anybody to think we had to show something we don't. Okay, so Medicaid rates and rate reviews. The governor passed an executive order back in 2019, I think it's 1902, when it was found out that we had not updated Medicaid rates in quite some time. And when I say quite some time, I mean some of our rates dated back to the mid to early 90s. They had not been looked at in that long. So as you can imagine, providers were coming forward to the legislature, to the governor's office, and to us asking for rate increases. So we have undergone a process since 2019 to review all categories of Medicaid rates. We are wrapping that up right now, doing the last of those reviews. We have done several rate increases. I don't have the amount in front of me right now. But several services such as occupational therapy, speech therapy, physical therapy got a rate increase. We've increased physician services rates as well, and then some other services as well. Assisted living received a small rate increase. So several personal care, which I think a lot of you here get, has also received a small rate increase. So we were very excited about being able to start this process, and we did it. We were trying to do it through a methodical look at each rate, looking at things the same way, using the CMS's standards. CMS asks us to look at how we are comparing as far as access goes. Are Medicaid clients able to access the service at the same rate that non-Medicaid clients are able to access the service? So we look at, have our utilization numbers gone up or down in the past few years? Have the number of providers providing the services gone up and down in the past few years? How much money are we spending on the service, and has that changed over the past several years? We also send out a survey to providers to ask if they limit access to Medicaid clients. And what their payer mix is, meaning how many Medicaid clients do they serve versus how many private insurance clients or Medicare clients. And then we also take a look at what our neighboring states are doing. We're in what CMS calls Region 6, which includes Texas, Oklahoma, Louisiana, and there's one other state that I can't remember off the top of my head. New Mexico, thank you. New Mexico. So we look at Region 6 states and see where we compare to them, and we also look at Medicare. Medicare pays the majority of the services that we cover, except for children, obviously. And so when it's a service that Medicare doesn't cover, we really do focus on what those other states are doing. And if we need to, we look at states that pay in a more similar way to us than those states. A lot of those states are what we call managed care, and so we expand a little bit to look at other states that pay how we pay. So those are the main things we look at. We send that report out to the providers. We get their feedback on it, and then we send it to generally somebody that is has an accounting background or an actuarial background to take a look at where we need to sit. If it's a service where we can just look at what other states are paying, we just do that. If it's one where we need to do a cost-based analysis, something like a facility-based service, then we send out cost surveys to those facilities to find out what their labor costs are, their supply costs, their food, and those type of costs are, and try to build out a rate based on that so that they know that they're getting compensated for their cost and able to pay for their employees and to take care of their clients. I think this is slide 10, so let me make sure I've covered everything on here. The last point here is just that in some services we are the market driver, so we can't really look at other payers, and that's why we look at what other state Medicaid programs are doing. Programs like that would be a lot of the programs that you guys are involved in, those home and community-based services programs, the waiver services, the personal care services. Those are not typically offered through private pay insurance companies or Medicare, so we have to look at Medicaid and other Medicaid states to really get an idea of where we stand and use cost-based type analysis to figure out if we're paying appropriate rates. So like I said, we're about to finish up the first cycle. I think we have about 3 reports left to complete. Everything else has been completed and is in the process of being sent out for comment, if it has not already been completed and updated. And so once we get finished with cycle 1, we'll go to the governor for direction on how to move forward with cycle 2. But our plan is to continue to have a regular cycle of reviews so that we don't have a situation where they haven't been looked at in 30 years again. And happy to take any questions on that after Mary's done.
Okay. So about the different Medicaid programs, there are more than 30 Medicaid programs that pay for healthcare services, and right now for over about 1.1 million Arkansans. And that includes our kids A and B, with enrollment around 387,000. Our home is next with 348,000. And then you can see we have 122,000 or so on parent, caretaker, relative. These are the main with the largest enrollment. SSI around 116,000. Newborns, babies within the first year of life, 49,000. And then our skilled nursing facility, 13,000, with assisted living facilities being around 1,000. And then our Medicare savings program, these are the categories for individuals with Medicare that are not receiving skilled care or long-term service and supports, but this is a program essentially that acts as a Medicare supplement for many individuals who qualify and helps with the Medicare premium. And we have around 11,000 between the DD waiver, autism, and TEFRA, and then our AR choices around 8,500, and adoption and foster care around 16,000. So general eligibility for Medicaid. Generally, clients must meet income limits based on a percentage of federal poverty level and the number of people in their household, so based on their household size. And it can range from less than 20% of federal poverty level up to 250%, depending on the category. Higher income limits for children and pregnant women and long-term services and supports, and lower limits for other adults. We redetermine eligibility annually. And Medicaid clients, all Medicaid clients are required to report changes in their household circumstances, changes in their circumstances within 10 days. And clients who are receiving long-term supports, services and supports, they also have to meet asset limits in addition to financial requirements and medical requirements, functional, institutional medical requirements. Look at our 2022, our annual eligibility limits based on federal poverty level. Traditional, under 20%, traditional Medicaid limit for adults. This is not non-pregnant and not LTSS adults. For a household of one, that income limit would be annually $1,488, for example. Programs that are at 100% of federal poverty level for a household of one would be $13,590. 138,000, which is the Our Home upper limit, that for a single individual is $18,754 a year. Our Kids A, $19,298, and then our Kids B and the pregnant women are at $29,083. And you can see, as the household size increase, the annual amount of income that would qualify under those FPL guidelines increases. We talked about this a little earlier in the PHE update, but just to hit the highlights, we have been continuing eligibility since March of 2020 unless a Medicaid recipient moves out of state, dies, requests that we end their coverage, or becomes incarcerated. And this is during the public health emergency. DHS, we continued doing our work. We continued processing applications, we continued processing changes and doing renewals to the extent we were able to through the public health emergency. So we know exactly who is extended and who is regular, who is regular and won't have to be renewed during the public health emergency. Now, as we mentioned earlier, clients could have been extended for many reasons. It could have been that they're now over the income limit. Could be they have aged out for the eligibility of that category. They may have also had a level of care change in an LTSS category that affected their eligibility. So because of all these different reasons why circumstances have changed, the different length of time people have been extended since we first determined them ineligible, we're going to conduct renewals on everyone before their coverage ends when we do the wind down. And that is all. Happy to take questions.
All right, it's noon, but we're going to take 10 minutes for questions or comments that any of you may have before we break for lunch. So if you have a question or comment, we'll start with Jerry. Just put your hand up and I'll bring the mic to you.
Okay, a lot of things have changed since the last legislative session. The Dobbs decision inflation. Also, the minimum wage has gone up. All of these things affect people's eligibility for Medicaid. Are there any plans to expand Medicaid, or any thoughts about expanding Medicaid to include, because before you pretty much had to be on minimum wage, but now that the minimum wage has increased, there's a whole slew of people who are going to be eliminated because of wage only from basic Medicaid. The United States has one of the worst mortality rates in the country for diabetes, for maternal mortality, for infant mortality. And within the United States, Arkansas has one of the worst. So we are the worst, one of the worst of the worst. Other conservative states have showed compassion and asked their legislature to expand, to allow mothers to start getting Medicaid services earlier and let it last longer for the infants and the mothers, so to reduce those mortality rates. Are there any plans in Arkansas to help reduce mortality rates with Medicaid by changing policies?
So there are a lot of different things we can talk about to answer that question, but I'll start with our recent policy changes that expand coverage for pregnant women to help women, new moms carrying infants. We have eliminated our limited benefit category. We had a category for those with higher income that just specifically only covered treatment related for the pregnancy. We have eliminated that category effective January 1st. This change became effective January the 1st. We have increased the income limit of our full pregnant women category so that it matches what the limited benefit used to be. It's same as our Kids B. And so we now cover all state plan, full range of Medicaid for our pregnant women. Another thing that we did to help address these things that you have mentioned that went into effect in January is in our Transitional Employment Assistance Program. The income limit since that program began back in 1996 had been $223 a month. So that income limit has changed and is up to $513 now for individuals. So that was more than double. That change went into effect in January. And yeah, I was going to say there are some others.
I'll talk to you a little bit about some other programs we did on the DMS side. So as you know, in our home well, you may not know, I don't know if we gave a presentation on it, but in our home program, which is our expanded Medicaid program, covers people up to 138% of poverty. We have a program called Maternal Life 360 Homes. And what that does is provides nurse visit, well, not nurse, but home visitation by a specialized person. It has to be an evidence-based home visitation program, the ones that are currently being run through the health department. And if you have a high-risk pregnancy, that person will go into your home and provide you services. For our home clients, that will go to 2 years after the birth. And that's regardless of whether or not you lose Medicaid eligibility or not. So we did get CMS approval for those women. Even if they lose their Medicaid coverage, their income goes up and they lose Medicaid coverage, that home visiting service will continue and we will continue to pay for it. Then we were able to, through Governor Hutchison's initiative for maternal support, expand that benefit to all women in Medicaid that have a high-risk pregnancy. So regardless of their eligibility category, they will be eligible to receive that Life 360 home visitation. Now, because that is a traditional Medicaid program, they have to maintain Medicaid eligibility to stay in it, but they will be able to get those home visits as long as they're Medicaid eligible. So we were able to do that and expand that benefit to all pregnant women through that initiative. So we're excited about that, and those programs have been shown to help with maternal and infant child mortality and morbidity. Like I said, they have to be evidence-based, so they have to show that. Now I'm going to let Janet take some of the other pieces if you would like, or I can...
No, you keep going. I mean, we've hit on the pregnant women, we've hit on the expansion of the category, and we're, with legislative session starting, we are looking at other options and ideas. Probably maybe add to the next time we all get together is a presentation on what we are trying to do for infants and children and pregnant women in regular Medicaid and in the expansion category, to show how we're trying to weave them together to have the same services for the entire category or the entire population. And so I hope that addresses some of your questions, and I'm sure there's always more that we can do.
And just so you know, we have pulled numbers on this, and in a normal year, not a PHE year, anywhere from 45 to about 60% of women actually stay on Medicaid through the Our Home program, the expanded Medicaid program. So we really only lose about 40 to 45% of women to Medicaid after their pregnancy, just so you're aware. It's less than half.
Can I just ask a question just to follow up on that? Do you know, with the legislative session starting, do you know if DHS would be in support of any bills that would be looking at presumptive eligibility, like Reverend Watson had brought up about ensuring that the mother and infant are approved prior to their actual Medicaid application being approved, or if they'd be supportive of postpartum coverage for up to 12 months? Because kind of like how you said about the rate comparison, you know, even with Texas expanding their postpartum coverage to 6 months for mothers, do you know if DHS would be open to supporting those options?
There is a bill that has dropped that is asking for 12 months continuous coverage. DHS cannot support or oppose a bill without permission from the governor, and I don't know if we have that at this point.
Well, I'll chime in.
I don't know.
So we actually did meet with Representative about the bill this morning, and actually I've asked for some data to be pulled to look at this, and we'll get with the Secretary and the Governor's office. So I'm not making any promises, but we are having a discussion. And we're looking at several other initiatives with pregnant women and children also.
I wish time permitted us to have more questions on this topic, but thank you to our presenters. If any of you have questions or comments that you didn't get to share, please email them to me and I will share them with the leadership. But right now it's time to break for lunch. Before we dive back into the program, two of our members came in after introductions, so I'm going to give them an opportunity, although they won't get to hear from all of you. Unless you go online, you can go online and watch the beginning of the meeting to hear about everybody, but we're going to give them an opportunity to introduce themselves to you. So I saw Brittany just take a bite of sandwich, so I'll start with Deronda. Deronda's a returning member.
Hi, I'm Deronda from Nevada County, Prescott, Arkansas. And I am here to be a voice, lend a voice, and extend some voices.
All right, and Brittany Gilmore is a new member.
My name is Brittany Gilmore. I'm from Sevier County, DeQueen, Arkansas. I have Breaking the Ties That Bind. It's a nonprofit organization that focuses on alternative sentencing for juveniles. And I'm a peer support specialist through the state of Arkansas.
All right, also before the break, Jerry asked a pretty deep question about Medicaid and eligibility, and a lot of our members did a very good job answering that question, but one of our DHS members would like to also provide an answer, and that's Secretary Putnam. So I'm going to invite Secretary Putnam to the podium and hear what she had to say on that topic.
Thank you very much. And I just thank you for the question. I wanted to just give sort of a global, this is the third full day on the job, well, if you count the weekend, which I do, fourth day on the job for me. We have an amazing team who's been involved and engaged with many of you on these topics and working with the administration previously. But what I did want to offer just from my early conversations with Governor Sanders and with some of the team is that they are hyper-focused on prevention and better utilization of prevention services. So that's one big thing, which can be a big deal in the expansion population as far as utilization of prevention services. But the other thing that the governor is prioritizing is child and maternal health and outcomes. And so I think that as we go forward, as we learn more from each other, those are some of the things that you'll see come out from the administration, and those are some of the conversations that their team, we will have with them and be able to come back with more detailed answers about what are some of the specific ways that we're going to reprioritize resources to focus on child and maternal health and other outcomes like that. So I just wanted to make that statement. I've been very, very impressed with and very hopeful with the approach that Governor Sanders is taking. I think she's made it very clear that she's, a mom and cares deeply about child outcomes. So I think we'll see a lot of focus on that. And that naturally means that we need to focus on families as well. And what are the family outcomes that we're looking at? How are we supporting families? So I just want to make that sort of high-level statement that, you know, we've got a lot of work to do. That's why I'm here listening and learning from all of you, is so that we can take back ideas to the administration. They've been very, very, really great to listen and work with. So just thank you for the opportunity to learn from you. Thank you.
All right, thank you, Secretary. So our next presentation has to do with the American Rescue Plan. You may remember when the pandemic began, the Congress passed the American Rescue Plan Act, and money was sent to all the states. Well, what is Arkansas doing with all the money we received? How is that going to benefit its citizenry? So Division of Disability Services Director Melissa Weatherton has some information about that. She has a slide presentation. So Melissa, welcome.
Thanks, Jason.
Hi, for the new members, so my name is Melissa Weatherton. I'm the Division Director for Developmental Disability Services. As you can tell from the makeup of the board, I'm very popular with you guys. I know a lot of y'all already because I've served in other capacities, or we've worked together trying to figure out services and how we could help. So please feel free to email me or reach out. The old time members do. So you new guys, feel free to reach out anytime you have a question or concern about a service for clients with developmental disabilities or delays. So what I'm going to present is a little outside my scope. So joke for the past, I don't know, year and a half that I must have lost a bet at DHS to be given this project. We, as a state, we're given the opportunity to apply for some very specific funding that we call 9817 American Rescue Plan Act funding. And the Medicaid director at the time said, hey, we're a little short on staff around here. If you would just write this plan so that we could get it approved because the deadline's coming up, then we'll have someone else run it. Well, joke's on me, guys. So I am the proud owner of the 9817 American Rescue Plan funding, but it's actually been a real blessing, and we're able to use this funding for a lot of cool things. So let me connect some dots real quick that aren't going to be on this PowerPoint. So starting back in 2017, we did a lot of transformation efforts when Governor Hutchinson first got elected in the spaces of the aging, the IDD, and the behavioral health space. Specifically, for the DD and the BH clients, we sunsetted an old program called RSPMI, implemented an independent assessment. So we have a third party that helps us with our independent assessments, and we moved those populations into an organized care model called the PASS. So that was phase one. Then COVID hit on our 1-year anniversary of the organized care model, and we had to put a pause on everything we kind of had in place for next steps, right? On improving care, improving services. Well, we luckily were able this past year to start those efforts that we had in place back then for 2020. So we passed a huge packet that went into effect January 1, where we added additional services for those members, and we added new provider types. And the provider type is duly licensed to take care of both behavioral health clients and IDD clients under the PASS, in hopes that clients will get better services because the provider will be licensed to provide both sides of the house. So that went into effect in January. So we are kind of seeing on the DDBH side, what we're utilizing this American Rescue Plan funding is kind of our phase 3. So American Rescue Plan funding is used for home and community-based services. So we're improving services for clients with IDD, behavioral health, and those that are physically disabled or aging. So that is just some background on kind of where we are on our phases and our long-term plans here. So let me see if I can do this at the same time. So like I said, I got asked to develop a spending plan. And in our spending plan, There was a couple of restrictions that the federal government told us we could do. We couldn't use the funding for anything we were already doing, all right? So the funding had to be used to expand or enhance a home and community-based service. And at the time, because this was turned in to the federal government in 21, as you can imagine, we were already feeling the hit of losing staff across those programs. And so our major initiative was a workforce improvement provider incentive plan. So I will get into more on that. So that was our major, which we wanted to give money directly to those providers so they could use it to recruit and retain the staff that they had. We also wanted to focus on enabling technology. So you can bill enabling technology under several of our programs here in Arkansas, but it's kind of like this hidden little gem, right? And we never took the time until this point to kind of build that out. Many states have their own provider type that all they do is technology. So it's specific providers who are trained in these endeavors. So what we're using the funding for is to try to build out that enabling technology provider type. I can't get any of this. Okay. And then I'm going to go through the rest in the slides because there's a lot more detail in here. This slide is super confusing, but let me just try to paraphrase what it's saying. There was strings attached to this money. And one of the allures was whatever money we could get out the door by March the 31st of 2022, the federal government would give us additional federal dollars. So we were feverishly trying to get a lot of money out the door to maximize the money that they would provide us. So we had all these great plans that we were going to use funds in all these different categories at first. And when it got down to the wire, we said, oh my gosh, we're running out of time. We have to throw all this money into the workforce stabilization payments because that was the fastest and the easiest way for us to get the money out the door. So we were able to send out to providers $115 million, which we then were able to generate extra federal assistance, federal match, so that we then could maximize those dollars for our other initiatives. So providers like personal care providers receive funds, IDD providers, behavioral health providers who are doing services in homes and in schools. So you have to be one of those home and community based. So it couldn't go to a facility, it couldn't go to the ICFs or nursing homes. It was restricted to the home and community based. And they could use that money for three things. They could pay people $1,000 recruitment bonuses to lure in staff. They can use up to $15,000 for retention bonuses for that same staff. That's a bunch of money if you think about it. And then they also, if a direct care worker cares for someone that has complex care needs, they can give them an additional $3,500. So the providers have been very supportive and grateful for the money that they got. They all did not receive the same amount of money. So I just want everybody to be aware of that. Like if you're saying, well, my provider's not doing that, it was really based on volume. So it was we based it on the amount of service they provided. Thereby, larger providers provided more service, more staff, and received more funding. So some providers that are really small still receive funding because we said everybody that applies will at least get $15,000. So if they applied, they at least got $15,000, regardless of if they had one employee or two, because we didn't want to disadvantage them for being small. And whatever money they don't use in the three specific categories, they'll have to give back. But we don't want them to give it back because we were able to maximize more federal dollars off of it, and that will be an auditing and funding nightmare for Janet. Yes. They have until, that's a great question. They have until March 31st of 2024 to use it.
They didn't have to tell everybody. I mean,
They didn't, yeah.
It wasn't announced in the newspaper.
Well, rumors spread quick. And it hit social media.
Yeah.
So, yeah.
So one got it and one found out and the other one, okay.
Go ahead.
So is there some kind of list that that's available out there as to if we can see if the providers in our area may have had something? I mean, I think that's a place that, like, as far as the line of work that I do, we can capitalize on it. If those providers are getting it, maybe we can reach out to them in our community and making sure they understand how important it is to spend all of the money. So is there a way that we can figure out what providers in our area?
I don't think there's anything confidential about the names of the people who received the funding for the company. Now, you know, I would want to put out publicly like the amount of money each one got, because that could get a little sticky. But yeah, I mean, I think that the list of the providers' names absolutely could be released.
Well, I'm the provider educator for the Sevier County Medical Center, so I'm just thinking
they did.
In my line of
I
work,
think they
I will
did.
be able to get out and like tell more. I mean, I know we got funding for the new center, but we haven't. We're talking about just the individual providers in our area.
Yeah, absolutely. So it was a little over 350 providers who received funding in this space. So, and we're hearing really good feedback. That they're able, I got some emails from aging providers for personal care because they were struggling, and this is actually bringing people in the door, and then they're able to keep them with this funding, with these bonuses, and keep the staff that they had, right? Because you can't do one without the other, or that doesn't work either. Let's see. All right, guys. So I just went through kind of how this works, and right now, so all the money in this bucket, this $115 million at this point's been distributed, so that bucket is zero, and so we're not going to be handing out at this time any more funding for this purpose. But what we're trying to do under this initiative right now is we have been building a IT platform so that the providers can go in and tell us that they have spent the money correctly. So they'll be going in and telling us the employee's name and what bonus they received in what category on what day, and then they have to upload payroll information so that we can reconcile for audit purposes to make sure that we're not having money spent inappropriately. So that will, should be up and live in February. And as you can imagine, that's quite an endeavor. We have one provider that received funding that has 4,000 employees. So that's a lot of employees. And the way the IT reporting system is set up is that drilled down, right? Because we need to know who the employee was and if they received the money properly. So we've been doing a lot of work to try to take that administrative burden off of providers, and we are having them submit Excel spreadsheets, and then we're doing all the behind-the-scenes work to get their pages loaded and ready so they don't have to hand key all those employees, right? Because the purpose of this was to help them, and so it's illogical to think, oh, but we need you to spend 6 days entering your employees, right, on the money we gave you when you're short-staffed. So we're trying to do some of that and take that off of them. All right. Enabling technology. So this initiative just kicked off, and the way we're handling all of these future initiatives after workforce stabilization is we're doing a round of internal DHS interviews so that we can see what our staff think and know who are having connections with clients. We're interviewing passes. We're interviewing some of Jay's nurses that deal with elderly and aging. We're doing all of this outreach to try to get a baseline of what people think is out there, what are we missing, and then the next phase is actually interviewing clients. So I know many of you on the, what'd Frank call you, OGs? All you OGs were contacted probably by our consultant Guidehouse to see if you wanted to be interviewed. But yes, okay, good. But I'm going to be signing y'all up to be interviewed after this presentation's over, all right? I got my sign-up list with times. So, like I said, we're really looking at different pieces of enabling technology. There's a lot of states doing a lot of cool things with, pill dispensing from afar, right? Where you have pill dispensers there. There's some alternative and artificial intelligence technology that New York is piloting for people that are elderly to combat loneliness. There's just a lot of products out there that I think we could use to combat some of the things that right now we are utilizing direct support workers that maybe we don't have to. And I know that's scary, and the last time I did this, a bunch of moms got upset with me because they said, you can't bring in artificial intelligence in lieu of a body, and that's not what I'm saying. We're not there yet, right? I don't think we'll ever be there. It will be a choice, but for clients who want more independence, this could be a very good choice. A lot of clients don't want someone hovering over them all the time. So we have to build out this service for clients who could benefit from it. And that's what we're doing under the technology bucket with this funding. Then, a lot of this is thanks to you guys. We realized once we set up the council this past year that it's mass confusion on what people understand with Medicaid, right? Medicaid's really convoluted, and we use words that no one understands, and it all builds on each other. And so, we have a lot of programs. So we are going to be utilizing some of this funding to do a Medicaid educational campaign that's going to specifically focus on what services are available out in the community. I know a lot of you guys, y'all's family is on the Community Employment Supports waiver. And I don't know that you know this, but 98% of our spend on that waiver is on one service called supportive living. Well, there's probably 18 other services available, right? But we never talk about those services. So a lot of services that could benefit people that are depressed or having some behavioral health needs. A lot of services that are just different from supported living. So under that PASS umbrella, any PASS service is available. But we aren't doing a good job of talking about those services. So not only would this educational campaign be for outside DHS, but it's going to have to be for our own staff, right? Because our own staff get confused. And then it also needs to be for PASS care coordinators. It needs to be for hospitals who are helping aging or elderly or physically disabled. There's a huge range of outreach we're going to be doing around this. And if you sign up to be interviewed for this, they would just be getting your thoughts on where you think most of the confusion lies and where you think we should tap to help educate people. So that is something that I'll be, again, reaching out and begging y'all to sign up for. This is really cool. So we have been trying to set up a mobile crisis continuum since 2017. I think we naively thought that when we put people in the PASS program, that the PASSes would help us develop mobile crisis. And that just, we realized, is not realistic because there's 4 organized care models and we need one model. And so it became very clear that DHS needed to drive the way that model looked. And when I say mobile crisis, I mean just that. We have needed for a long time to help people stabilize in their home or at school or in the community and not be transported to an ER or to a more restrictive setting, because then it's even harder to get them out and get them in the right placement. So we are looking at several models. We're looking at Arizona. We're looking at Georgia. There's several states doing this really well. More than that, our consultant, Guidehouse, is helping us build this. And this is being led by Paula Stone in our office, who is the interim children's clinical director. And so she's driving this today, but I'm presenting on her behalf because she had a meeting. But she's doing a great job, and we are, we've been talking to legislators and trying to get them aware of what we're doing, because we're about to go into a session, and we want them to know we're actively working on this. So please, please help us get on board with this plan. But we're thinking a statewide hub where we'd be able to take in calls from 911, 988, all these different places people call, right? Put it into a hub, do data analysis in that hub, deploy mobile crisis from that hub. So that is the concept, and utilizing our money to build that concept is what this initiative is about.
I have a question on,
Yeah.
on that aspect. Are we looking at the Minnesota model as in only 48 hours to hold somebody in a jail setting if they're having a behavioral health crisis? Because
No, but we will.
Yeah, that's where the big thing lies. I mean, if you put me in a turtle suit in a cell with no TV or anything, I'm gonna go insane. And I think that I'm kind of mentally sound as far as so to speak. So if you take somebody in the middle of a mental health psychosis and you put them in a jail cell in a turtle suit with no communication, then obviously it's gonna maximize it and make it way worse than it should be. And I know that's just something that they enhanced on. 48 hours, they need to be moved out because, I mean, like I know people in my community that are waiting 24 months. I know one lady in particular, we've been waiting 19 months in a jail facility waiting on a mental eval from the state hospital whenever Sevier County doesn't even have a mental health therapist through Southwest Arkansas Medical Counseling, which is our state representative.
Yeah.
So what do? We have all these people that aren't getting services because our state is backed up, but we don't even have a local.
Right.
Is DHS looking at maybe like some forensic
Yes.
psychologists that are being able to step up and do those interviews for us that are just like crammed
There
in
is
the
a
system?
lot of work going on in the forensic space that's really outside of this. So the goal of this is to never take them to jail, right? But I will say that what you're talking about is being looked at in this other arena of how do we improve forensics. Jay Hill's here if there's specific questions. But yes, it's been looked at and for a while now, and now we have a new administration that I think will have a fresh look at it, and I don't see that going away. So I think we'll have to keep looking at that. This is really trying to get in front of that in a way to try to cut back on what's happening, right? So this is to send out someone live that can de-escalate on site so that they don't have to be transported. It's interesting, we were pulling data for this. We have about 54,000 people in our past programs right now. And about, let me think what the number is. I would say 35 to 40,000 of them are children, right? So what we're starting to realize is 988, and I don't want to say anything bad about any of those programs, but they're not really designed for children, and they're not designed for people with IDD for sure, right? So we're trying to think of a model that's going to work for our entire population, which is behavioral health, children with BH and IDD, and then adults with IDD. And a lot of states are using iPads and doing telehealth, and we're really trying to stay away from that because we don't think iPads are going to work for people with IDD when they're in that kind of acute crisis moment. So that's why we've been focusing on the two states I mentioned, because they are live bodies and they are serving the IDD population and doing well in those states, going out and de-escalating. Yeah. Yeah, me too.
That would be a great goal or next step to start looking at as we start and grow ways to improve. Because I know the transportation has been an issue, and then you just add to it with a mental health.
Yeah, well, I know Conway Behavioral Health is doing like free. They'll send you a transfer order to get them transferred on the EMT. We're about like 6 broken iPads in, so that is not. I'm just gonna tell you right now, that is not a good possibility.
No.
It's not. Most of them are scared of technology if they made it to that point. So.
Yeah, and I would like to see some continuum of care to where if you're addressing the
breaking moment and you've gotten stable and doing the appropriate responses where telehealth fits, then it's an option for maintenance. And so it's not an option for, you know.
For the moment, yeah.
Yeah, because we'll be wearing the iPads. I mean, you just don't know what'll happen. And so that way you've got different steps of care throughout the whole continuum.
I made a note of this, and I'll have Guidehouse do some research for us. Miss Yolanda?
So when you talk about the mental health, because that's kind of where I am with the behavior health with mine. When you talk about like community and crisis responses, is there any type of way, and I don't know if this deals in with your grant, that you can maybe even house people in the schools, especially secondary schools, because it's ridiculous, but that you can house people that can help these teachers, because like the teachers are stressed out, and since the pandemic we have so many kids with behavioral health that has come back to school and then there's no help. And we have, you know, with the past, and we're thankful that we have places like Life Strategies, the school-based counselors that can come into the schools, but they have so many students that they have to see. Their load is heavy. And so, and then when you talk to people like my son, he's in special eds for emotional distress. And so when you hear the teacher said, yeah, we're short 2 special ed teachers, and he may or may not get this, and that, or if a crisis was to come, your school-based counselors is at another school. They can't get to you, or your QBHP person may be with another school. But you have some schools that are able to have your school-based counselors and the therapist and the QBHP person there on site. But there are so many schools in these different districts that are not able to have like on site. And so when you have therapists that are trying to see students, they have to go through the child's schedule, especially in secondary is what I'm talking about. You have to go through the child's schedule, and, oh, you can't get them during this time because they have a core class. You have to wait till they go that, and it's so, but that, and also somewhere in there where you can have, where staff can be trained with behavioral health and things for mental health from the therapists that may be available to train them and to help them to understand when a child may be having a moment, or to not necessarily call the security and, you know, make matters a whole lot worse than what they are, but to know what to look for and what things to look for. And like I said, and maybe even having something on site. And I'm not sure when you say community and stuff, if that includes the school district.
It does.
Okay.
It does.
So that's something that I would love to be able to help with or add information about.
Well, full disclosure, so I recommended Yolanda to be on here. So I'm going to pick on her. She took care of my babies at St. James, so that's how we know each other. But we just set up that service. Let me talk about it.
We are so rural up in Sharp County that our services may have to go to Little Rock. And it's a 3.5-hour drive. You've got a kid in crisis. You got to call somebody. Well, they're going to send somebody. And you're already 6 hours, 3 hours there, 3 hours back. And they may have shot up the McDonald's before you get there. I mean, and we need to have areas all over the state, not just, Hardy, you know, we're way up there.
No, and that's how we're trying to set this model up. So there would be time restrictions on how fast they have to show up. And it'd be community-based teams across the state, right? Because it's not going to work being housed out of Little Rock. So it's got to be community teams. And what we're going to try to do, and I say all this, and I'm not even briefed the new bosses on it. So this is a little awkward.
She hasn't really talked to us. It is day 4. But mental health, behavioral health, and services in the schools is on top of the list of things to address. So you're on the right path.
I know. And I wasn't trying to maybe be like I'm going to get this group on board with this and they're never going to be able to shut this down. It was already on the agenda. But it is making me sweat a little. But Yolanda, so we set up a service that went into effect January 1 called Intensive In-Home for Children, okay? And it's a team-based service where paraprofessionals are doing this service under the supervision and training of a clinician. All right? And it's exactly what you're talking about. So like if a child leaves a residential or a psychiatric residential setting, a trigger point would say, the PASS needs to offer intensive in-home. Intensive in-home can be done in school. So the service doesn't have to be done every day. It's kind of like they're on call. So if he has a crisis, you know exactly who to call because you have a team of people that's assigned to your child, and you call that clinician every single time, and they're required to show up. So that's the service that went into effect. Now, I'll tell you this. It's an evidence-based service. And so there's a training dollar amount that goes with an evidence-based model. And so we asked and received $5 million in funding from I call it the big ARP, not this, like the money that the state of Arkansas received under American Rescue Plan. We asked for $5 million, and that was awarded. That will go towards training these teams across the state to do intensive in-home. So they're not up and running yet, but we put all the coding in, we set the services up, it went live, now we just gotta train them. It's coming, yes.
Where do we plan on getting these mental health professionals from to activate this team? I mean, we're medically underserved. We were in the top 10% just recently for medical underserved states. Yeah, shifting. I was going to say, so like the peer recovery support system, that is something that learned experience. Like, I mean, with people like Yolanda, they may be able to like get some of these moms to activate some of these teams.
So what it is you're exactly right. We do not have the clinicians across the state to be seeing one-on-one patients. We just don't. So we have had to we're gonna have to shift the workforce where there's a clinician that's over teams and they train paraprofessionals and supervise teams because there's no other way right now to do it. And it is a good model, just like you being a peer specialist. I mean, that's a great model that's effective, and it's been proven that it works. So we think this team-based approach can work. It works in other spaces.
From experience, as a department chair, we had Conway Police Department come and speak to our students, and they are teaming up with Arisa Health right now, which you may already know about, and they have a crisis team that goes out with their police officers whenever there is an individual with a mental health disorder or anything, and it has been doing great. I say that not because my husband is on it, but everyone in Conway have been saying great things about the partnership when it comes to serving individuals with disabilities. So I'm looking forward to seeing this go active across the state.
Yeah, and I'm glad you're saying it's working because that's a SAMHSA grant. So, the SAMHSA put out a grant, and it was awarded to several community mental health centers across the state, and Arisa was one of the awardees before we applied for this money, right? So we're actively waiting to see the results of the pilots that are happening to see what worked, what didn't work, and the timing should be really good on when we put our plan together to be able to incorporate those concepts. But I'm really happy to hear that it's working. That's great news. They're gonna kill me. I'm taking up so much time. Okay, let me. I can hear myself talk for hours, guys. Okay, let's see. Okay. So, improved transitions. This work stream is just now kicking off. All right. This is really going to be focused on transitioning. For the GD and BH clients, it's transitioning people out of psychiatric residential, out of the state hospital, out of a more restrictive facility, back into the community. Where are we breaking down? How are we going to do it better? What kind of placements are we missing, right? Why aren't they transitioning? That's what they're looking at here to try to fill these gaps. On the aging and the elderly side, oftentimes if someone has to go to the hospital, it's easier for them to be transitioned to a nursing home rather than be on one of our aging waivers that Jay runs, because it just takes time to be processed for a waiver. I mean, on average, for one of our waivers, not with a wait list, even if there's no wait list, right? 22 years is extreme. And I really want to talk to you because I should have only been 13, which is still awful, but it still takes on average, even with no wait list, about 90 days, right? And it's hard to cut the days and click the time away. So by that point, hospital's like, you got to get out, grandma, and we're going to move you to a nursing home. So with this transition for those clients, we're trying to figure out what other states are doing so if people can go home, how do we get them back home while they're doing the paperwork? And I'm not talking about presumptive eligibility, okay? That's a dirty word over at DHS. But I'm talking about, are there other options that other states are utilizing that we too could maximize in Arkansas? Oh, God. Mary, I'm going to yours. I will say one last thing. There's a new initiative that's not on the slide deck yet. So we know, and we've been hearing a lot from providers, that there's going to be this cliff. So we, handed out $115 million. What's going to happen when that money runs out, right? This is cool that y'all gave us all this money to recruit and retain, but now what happens when the providers use it? And we agree. So we have to think about some long-term strategic planning to support home and community-based services. So we have actually looked at adding an initiative that would do that landscape for us, that would go out to see how many personal care providers are in certain areas. Where do we have deserts? Where are we missing services, like in your area, right? So just doing that landscape so we can get a better idea of where the home and community-based services are located across the state so that we can see how we can help support maintaining them, right? Because it is our goal to maintain people in their homes if they're able to do so, and we know that we need to help support that effort. So, okay, I'm done, but I do want to ask y'all, if you want to be interviewed to complain about the following, sure, okay. I will put this up front here and get y'all to sign up, but we just have different time slots for each one of these initiatives, and then Guidehouse will be calling you and getting your opinion so we can incorporate it into what we're doing. So make sure we hear everybody's voice. So thank you so much for listening to all of that. I appreciate it.
You guys have already asked a lot of great questions. Is there anyone that we didn't get to that has a question about what Melissa has presented? Betty?
Directly related, but it tangentially is related. Your direct service providers, probably the lowest paid employees that care for people who are medically fragile, mental health issues, all kinds of issues, and they're paid just barely a minimum wage. Something has to be done about that. You can't continue to provide services to people who are really need support with that kind of wage structure.
Yeah. So let me say this. So it's two different concepts. So let me separate them. So the pass, let me talk about that in one way, and then let me talk about when you're outside the pass and you're billing us direct. So when you're outside the pass, billing us directly is kind of what Ms. Pittman was talking about earlier. Currently we're under an executive order where we're reviewing rates every 4 years, and she's almost finished going through all the providers, right? So those providers who bill us direct either have been or will be reviewed to see if their rate is sufficient. Pass is different, so I just want to make that clear, and I know you have an outstanding question I need to answer, I think, on an email. I'm trying to get there. So the passes are paid very differently. So because they're set up under managed care rules, they're paid a prospective monthly payment in advance for each one of their members. And it operates like an insurance panel, right, where you can move the money around. Under managed care regs, your rate that you pay passes has to be approved by CMS for actuary soundness, and it is. So we don't set necessarily a rate for a service. We're setting a rate for a person, if that makes sense. Now, I will say, we thought the market would kind of take care of itself and that providers would be able to negotiate their rates in a better way with the passes, but a lot of these providers are small. And they don't have the manpower, the backing behind them to get their biggest bang for their buck, so the passes have been hesitant to negotiate very much. So we are looking at that on setting some sort of floor payment for some of these services, because we did think that it would play out a little bit differently than it has. The passes, though, each one pays different rates, right? So it's still going to be them signing contracts with providers and negotiating rates, but we are nudging them more than we were.
Always looking for ways to cut waste and improve efficiency so that we can have money to do the things we want to do. All this language is new to me. Our waiver provider, we should be getting supportive living. We're not just yet, but we will be. That care manager person who supervises the workers has to come to my house once a month. Is that a rule just of their agency? Is that a rule of Medicaid? Is that a rule of the PASS?
Your PASS care coordinator is coming to your house?
No, the waiver provider.
No, they don't have to come to your house every month. They don't even have to make contact.
Okay, I just wanted to make sure it wasn't, because what's happening, and maybe y'all can nudge them in this, what's happening is that, now this woman's been to my house, she spent 4 hours at my house, that she could have spent out finding me a caregiver. She's coming to ask me how the services are going. We're not getting services yet.
PASS care coordinator?
No. I don't mind her coming. She does great work. We talk about real
Maybe
things
this woman
and solve
just likes
problems.
to hang out with you, Allison.
This is the waiver provider. This is the
Okay.
supervisor of the DSPs for the waiver provider.
No, it's weird.
And
No.
I'm like,
we can
why
talk
are
about-
you here? Go
I
find
don't
me a
know.
worker. Okay, thank
Yeah,
you.
I don't know. So a PASS care coordinator is required to do a face-to-face visit every 3 months.
Yes. What about a provider?
No. Mm-mm.
No.
Mm-mm.
Hi. Are you positive? Because I've heard that from several providers as well. They are required to make a monthly visit.
No, I'm positive. No, they're really mad about this, right? And so what happened is they used to do their own case management. When we moved people to the PASS, they got super mad because we were paying them $100 a month for that service. And I've never heard the end of it, that we took that away from them and gave it to the care coordinators. So maybe that's just something that they're doing some quality assurance within their own hierarchy.
So was that switch to supplement the monthly visit?
So listen.
Did that transition to the?
On AR choices, and it's a different rule. So I'm only.
I'm speaking on the past.
Okay.
Was the transition? Was it taken away from the provider and moved to the care coordinator?
Yes. Yeah. Back in 2018.
Because that's what I don't think the providers are getting, because they're still. Some of them are still pushing this monthly visit.
Well, let me put it in education, because I think they do know, because they can't bill us $100 and they complain about it at least once every 3 months. But we can put that in the education pieces. And if you want to talk to me after this, we can see if I can get her to stop coming to your house.
Thank you, Melissa.
You're welcome.
I'll just tell her. Just tell her, no more.
Thanks, guys.
All right, so I told you guys at the top we had a full agenda. What I personally didn't take into account is when you expand membership, you also expand the Q&A period. So we have one more presentation we're not going to get to today. We're going to have to punt that to next meeting. It's on SNAP and how SNAP tries to combat some of the problems that Jerry mentioned earlier in the meeting. So we'll have that presentation next meeting. Right now, though, we need to elect a co-chair or a vice chairperson. So of the new members, have you given it some consideration? If you would like to be, if you'd like to throw your name into the hat to be the vice chairman this year and the chairman next year, just raise your hand. I'll bring the microphone to you. You can share a couple sentences of why you think you're the best person for the job, and then we'll take a vote. I've handed out some pieces of paper. We'll vote on it. So, anybody want to take a run at it?
I'll do it.
Okay.
What do I say?
What in your past or what qualifies you to be vice chairman this year and chairperson next year?
Gosh, I just want to be an advocate. I just want to I mean, gosh, guys, these families are, everything. I want to make Medicaid the best it can be. And if you elect me, I'll do the best I can do.
Anyone else of the new members want to nominate yourself for this? If not, it'll be a quick vote. All right, well, Kristen will be our vice chairperson this year. So you will work with Jerry and make a great team. We also have time at our meetings for open discussion, which means, it's not restricted to the topics that we present to you. If you are having an issue that someone in your community has brought to your attention or that you're experiencing personally, we have the DHS leadership that can hopefully answer your question or address your concern. So if there's any comments, questions, anybody has on their mind, Medicaid related, feel free to raise your hand, ask your question, and we'll see if we can get an answer.
I just want to say thank you for your time. It's been wonderful today. I appreciate your time and your expertise. Thank you so very much for spending time with us. Thank you.
Anybody else? Yes. Oh, you got a mic.
One of my major concerns is that about mortality rates in Arkansas. As I mentioned before, the United States is one of the worst industrialized countries for mortality rates. And within the United States, Arkansas is one of the worst states. I mean, there's a couple states worse than us, Mississippi, basically.
We're thankful for Mississippi.
But, it's not a good category to be in, And when you look down at detail into the data, you find that low income and people in poverty are the ones that bear the brunt of these negative outcomes, whether it's diabetes mortality, whether it's infant mortality, whether it's maternal mortality, There are a lot of people dying, and even with COVID mortality. Now in the state of Arkansas, DHS has a supercomputer, and we have a control center. And there are tools like Power BI and Tableau and so forth, where you can do deep dives on data and do analysis that can really help people. And with new decision making and looking at what other states are doing. But it appears to me that all the state of Arkansas is doing with this technology is simply finding ways to get people to be discharged from their benefits. Not trying to help people utilize their benefits more effectively or to increase the pool of people who have benefits, but to decrease the pool of beneficiaries. And I think that's a mean way to use technology. Does anybody have any comment on that?
I raised my hand on that one. I understand your points completely, Jerry, and I do agree that sometimes technology is not used the way it was intended or not used the way it's most effective. I might get a little controversial. Mary? Well, I might get a little controversial here, so forgive me, and I'll hear about it if I do. But all the data and technology and analysis in the world can't completely address the root cause. And some of what we need is workforce and economic development and access to opportunity combined. So I know that doesn't answer your question, but it's a lot of work that needs to be done that's not specifically in the benefits realm, it's not specifically in the technology realm, but those are pieces of it. We need the combined support system that is providing access to opportunity in the right ways, so that we're able to look at data and do deep dives in data into those lower income areas and into those health disparity and income disparity areas
to see what are the paths that we can provide collectively as a state. I came from Kentucky. Kentucky does not have great outcomes either. We've got very poor chronic condition mortality rates, very low pockets of poverty, and so a lot of the answers lie in what can we do to increase access and opportunity and prevention services. And I know you've heard me say prevention before. And with that, Jerry, I totally agree with you. The ability to use our data and our technology for further analysis and where are we being effective, how is it working, and how do we repeat that? So I think that again, and Mary, if you want to chime in on the technology side, there's a lot of technology that is in place in Arkansas, and I'm learning. Remember, it's day 4 for Janet and me. But a lot of the technology that is in place, I think we are able to use the BI system to take a look at pockets of areas where we're consistently having poor outcomes.
Right, and we do send it. I will say this: nothing we do about going about the daily business of implementing our Medicaid and SNAP and T programs or any of the programs at DHS that we're responsible for is intended to be mean. But we do have to follow requirements and make sure that we want everyone who is eligible for services at DHS to receive those services. But we also have a charge to make sure that those who are receiving the services are eligible to receive the services so that we maximize the resources that are available to serve everybody. So we do send notices. There are things we have to do, and sometimes people's cases do get closed as a result of that. But on the technology front, where you were talking about how we could be using technology better to create policy or examine where issues are, I just thought I would mention that in county operations, our team applied for a USDA grant to build a longitudinal data system. Now, so we are building that, and as one of the requirements of that grant is we'll be providing information about our SNAP caseload to the U.S. Census Bureau. But beyond that, this longitudinal data system, which we can use it in collaboration with the state's longitudinal data system. And now that when it's built, we can use it across DHS to gather information and study things and use that information to help inform policy decisions in the future. So we're going in that direction. Wanted to let you know.
Any other, Betty and Brittany?
I'm not sure really how to say this, but I'll go back to the fact that my son is 35, and I've been involved in Medicaid and supported living and all of those things for 35 years, and I'm sad that there's still 1,000 people who don't have waiver services. And shame on Arkansas that we don't support those folks. And there's so much money that's being spent. I mean, we're talking about millions and millions of dollars has been spent over the years, not just this year, not just last year, but I'm talking 35 years since he was born. So I just think we should be doing a better job, and I don't know how we do it. I heard a lot of things today that I'm encouraged, but shame on us for it's taking this long.
So back in, oh my gosh, it's all running together. Last December, Governor Hutchinson and I did a press conference where he mandated that we eliminate the wait list as it stood in 3 years. So that's why I think many of you guys are saying, I'm finally getting waiver, I'm finally getting waiver. Once we, and we have 1 year left on that, by the way. We're in our final year of releasing those 3,000 slots. And I'm very happy to report that as last time that I looked, which was last month, there's not a wait list building back up, which is great news because I was very worried, right? That, once. That's right. But we also have unfortunately probably about 300 people that die every year. So if we can get this big weight backup on services, what I'm hoping is we won't have a backup like we had, right? It just took too long to get money to pull these people off. But the General Assembly gave us the funds over at DHS so we can afford to support these people. They made it a real priority
under the last administration, which I was really happy about. But yeah, I mean, we are should have at the end of these 3 years about 8,000 clients on waiver, and when I started 7 years ago, we had 3,000. So I mean, it's just a huge improvement.
Our politicians are, I'm saying Arkansas, not the services we're providing. So that was not a slant to anybody.
We're very hopeful that, like Christy said, if we are all about prevention, then we will want to be preventing things like wait lists, and we'll want to be preventing things like people waiting on services. So I don't know yet what her policy will be, what the governor's policy will be on DG. But if she has a heart for children, and like I'm being told, then I know she'll have a heart for people with IDD as well. So I'm very hopeful that we're about to go another 8 years with a very supportive governor.
So I guess my question's kind of like a response to both of you are talking about. So we talk about like 44% of Arkansas is severely rural area. Has DHS entertained the idea of maybe like compassionate care teams in that area to go out and visit? Our literacy numbers are low for our adult literacy. Our childhood literacy in Arkansas is amazing, but adulthood, it's not great. So in-person first response, a lot of these services are closing, and people are not getting their stuff turned back in time simply because they don't understand. I mean, and we have pride. If you're in a level of poverty, all you have is your pride, so you're not going to stand in the middle of an office and say, I don't know what you're talking about. But are we maybe looking into maybe using some of this excess money to get like teams, nonprofit advocates or something in these areas that will go out door to door to these people that are getting their services constantly connected or interrupted, and maybe like taking the time to sit down and explain to them one-on-one so that they can make sure their services remain? Because again, prevention, that's going to prevent the wait list. If we keep them in their services and keep them updated, then we're not going to be having to go back to the 30-day restart of services because your service is closed. And a lot of times it's because they don't understand. And I mean, we kind of got compassion fatigue in DHS right now, so it's not really, they're not so nice whenever they're trying to ask these questions either.
Yeah, I wanted to add on to that. As an end user of these programs, my daughter's only 4, and I feel like I am privileged. I live in a home that has electricity, and I have a lot of things that people in rural communities probably don't have access to. My husband's an attorney, so he can read all of the documents that come in from DHS. We get so many different letters, so many renewals. I don't know what is important and what is not. And when I get something in the mail, I'll go to the provider and I'll say, do I need to be worried about this? And they'll say, oh no, this is just one of the things that goes on behind the scenes. So that's exactly where I was. You're talking about a crisis care team. Is there someone that you can place on those teams in those communities that can just kind of, I know we have caseworkers, that are assigned to us, but honestly, I don't know her name. And anytime that I've asked for help, I don't think we've gotten what we needed from her. So, and not that she's a bad person or is doing a bad job, but she just may not have the information. So as you were talking about education and educating providers and people who are going into the communities, I think that having somebody on the team that that you can contact is helpful. I mean, obviously the ideal would be that everything would come from one department and you would only have to fill out these forms one time. My kid has Down syndrome and that's not going to go away in her lifetime, but we still have to do all of the things every year.
You want to talk about that, Brad? We are changing that.
Yeah.
We understand that's wearing people out.
Well, I think we can take that idea, definitely that feedback back. But we don't have that today, but we do have an office in every single county with staff there who can get you the answer to your question. If they don't know the answer, they have access to many other staff who can help get the questions answered. I know that doesn't always go as it should on the first inquiry, and I'll just let anybody know if you need to, you can contact me and I'll make sure your questions get answered. But that is also part of the reason why when we launched this new eligibility system, we expanded our website so that a lot of things that you would have to go to the office for or call the office before in the past, you can do it online if you choose to and if you're able to. But we're still there in those counties if you need us. We even have kiosks in those lobbies where we can help you if you want to do it online. We can show you how to do it. And the notices, just if you call anybody, we can see them. I mean, we have universal caseload. People don't have one caseworker anymore. This is what I'm messaging to my team, and we're going to work on messaging to everyone, because we switched to universal to help us make sure we got things done on time. So the next available person does the next available thing. So you may not have one caseworker. You've got the whole team. You've got all of us, and we're all going to work together to take care of your needs. So, and on notices, when we implemented this new system, we went through months of revisions to notices and really, really worked to make them better. And I think we did make them better, but we're about to go through another round of, now that we're using them and we see what they say, because in testing, when you're developing things, it's very hard to see every possible combination of notices. So now we have some actual experience over the last year or so, and I'm going back to my staff, and you guys also feel free to let me know what you've experienced on your own and saying, for notice improvements, because we're going to do another round of notice improvements, because I'll just give you an example. If you're being approved for a service, a category, you don't necessarily need to know that behind the scenes the system looked at 5 other categories and denied you for those but approved you for the one you got approved for. That's really confusing, and I've seen that on a notice. So it's stuff like that that I'm talking about. Now that we've done this, what do we need to do to make it better from here? So it's always a continuous process of improvement. Yes, ma'am.
Also want to add that I have noticed an improvement there. The one takeaway that I had is the times that I've been able to get things accomplished are times when I've had a person that I could identify. So if you could think about, when we call you guys, we're angry. We're in crisis. We've gone through all of the, we've contacted people. Nobody's answered the phone, and it's not just you. We've worked with providers, and we're angry at everybody at this point. But anytime that I've ever gotten anything accomplished, even when my daughter was born, I didn't know which way to turn, and there was one person at Children's Hospital who was like, here's what you do. So when you're thinking about your teams, if you can just identify a person or a few people, I think that, and I'm sure that, I have, no knowledge in this, but I would think that psychology probably backs this up, that when you've got a person that you can go to that can help you through this, it kind of helps with prevention.
Right. And we do still have experts. It's just the person at the front desk may not be the expert. The person you first reach on the phone may not be the expert, but they should transition you well to one of the experts so that you get your question answered.
So we have a whole intake office. That's all they're assigned to do is help y'all. So Mary's staff sends them to my intake office, and it's run, and we have staff stationed across the state, and you do get assigned one person. So you would be like, there's a go away.
Right.
There's your person, right? And that's who comes to.
Hold on. Everybody in this room that hasn't heard of that, so I don't know if we're communicating correctly.
Well, let me send you the number to DDS intake.
I've been in this 33 years, I never got assigned anybody.
Yeah. Well, I set up the joint intake about 4 years ago. Well, y'all are calling me too. But yeah, we're doing, I have a whole unit, guys, it's like 30 people. So my question, I know she has a question, I won't take it, but I'll just.
I was going to tell them about the tariff change.
Like, I'm hearing them say that or I hear you say that there are services, and you hear everybody say, we never hear about it. And I know one thing, I was gonna say something about was communication wise, because one thing with my son, he's with behavioral health. And so when you call and you ask them, like, hey, my coordinator told me that this would be the good number to call to try to get services, and can he get this? And then they'll say, so does he have any physical disabilities? And I'm like, well, no, but well, no, we can't help him. And so then we're off the phone. And so when I tell the people at our total care, and they ask me, oh, well, you should be able to, I was like, no, that's not what's said. And so maybe what could help is like when, like you're telling us that, we offer all of these services. When our past coordinators come to us, and they know what our issues are,
maybe come with a resource list to say, okay, these are the things that are offered to you, because it always seems like they want to listen to us and tell us what we have, and they go, well, maybe we can do this, and maybe, but if we already know ahead of time that these things are here, and maybe this is where you would go to call this, and we're able to discuss those things with our coordinator, then it will help us, because a lot, especially with me with behavioral health, I'm a parent going in blind. This wasn't in my book, you know. So as I'm learning the journey through him, you know, I'm not only a teacher or a director, I'm learning, I'm a student, because this is a new journey for me. And so when most of the time when we're talking to our coordinators, like they say, we're in crisis because we're trying to figure it all out, but also pay bills and work and do other things. So if we know that these things are already there in place for us, then it wouldn't be so hard to try to connect the puzzles in the end. And then when we finally get on the phone with you guys, we're angry. So maybe that, or even I was writing down, like when colleges do, like for instance, my oldest child, when she was getting ready to go to Fayetteville, they had like this big campaign with the college, like, hey, we're coming to your town, and we're going to have all of these different services that your family are able to do. So when you have like the team or something, maybe do use some of that money as a campaign for the state of Arkansas with Medicaid and DHS, with IDD, with behavioral health, and say, hey guys, we're coming to your town and we're going to bring all of these resources, or have some type of fair or vendor type thing where these families can all come and say, okay, this is what we need and this is what we need. And in that way, you can also get what you need as far as information from these families that have issues with all of these questions that they're having.
And there, earlier when you mentioned, you know, filling out papers over and over again, and how if you have a diagnosis, you're going to have that for a lifetime. One of the things I stood up here to share with you is, I got sidetracked, but TEFRA, is a waiver. TEFRA program is a waiver, and that program was recently up for renewal. And as part of the renewal process, we have requested to make some improvements to that so that certain diagnoses will not require that annual medical redetermination. However, it's coming. It's coming, not as fast as we wanted it to, though, because CMS has extended our current waiver until they can get the review process done for our renewal request. And I think they told us it would be about a year when they extended it. But we are working on that, just so that you know, because we know that paperwork can be overwhelming, and doing the same paperwork every year when, you know, for certain conditions, it's not going to change. So just want you to know that's coming.
All right, we have reached our time together for this meeting. We will meet again on the third Tuesday of March, so we look forward to seeing you then. Be sure to sign your mileage reimbursement forms, leave your folders, leave your name tags, and this is your meeting. If you have ideas for the agenda for the March meeting, email those to me, and we have a meeting 1 month out at DHS where we put together the agenda for this meeting. So if in the next month you make a suggestion to me about an agenda item, I can assure you it will be discussed at that meeting. I can't promise you it'll be on the agenda, but we'll discuss it and consider it for the next agenda. So thank you all for being here. Safe travels home, and we'll see you in March.